Right. Before that, I would have to say that the kidney transplant, now the major problem of why we lose the kidney is actually rejection. This is something 20 years ago, we didn't think it was a major problem. So with that in mind, we want to treat rejection or diagnose rejection earlier. So some might say, okay, if rejection is a problem, then prevent rejection. The problem with that is we cannot just giving more and more immunosuppression because it has a side effect. And one of the problems with immunosuppression is you get infection and cancer. So that's why we need to have a balance for giving certain level of immunosuppression and be able to make a diagnosis of rejection earlier so we can treat them better. So the problem then is, as of now, we use kidney function, the serum creatinine, as a marker of rejection. But by using a function test like the creatinine, it takes a while for the kidney rejection to happen before you start having the impact on the function itself. And then we lose that window of opportunity to treat the rejection. So that's the problem we have. Right. At UCLA, we were involved in the earlier trial of the cell-free DNA with another company called CADX, and that was in 2015. And the paper came out in Journal of American Society of Nephrology in 2017 that led to the approval of the test. So 8 years ago. Right. It's a simple question, but pretty complicated to answer, right? What we do learn today is we make a diagnosis of rejection. Gold standard is to do a kidney biopsy. One of the things is, you cannot keep doing biopsy every single day or every single month. So unlike kidney failure that defined by retransplant or dialysis is arbitrary to say when the rejection happened. Is it happen when you make a diagnosis by the biopsy? Or even the patient, like in this case, right? If we say that the marker that we look at cell-free DNA from the Prospera test, make a diagnosis, it go up earlier than rejection. You could make an argument that the rejection actually happened when the cell-free DNA start to go up. As most of us know, the cell-free DNA is a marker that we use to look at the DNA leak from the donor. And the idea here is the DNA leak from the cell into the bloodstream for us to pick up by the blood test when the cell is damaged or broken down. So you could argue that you see evidence of injury, in this case in the paper, 6 months before AMR and a few months before ACR. Maybe the thinking would be the ACR or the AMR actually happened when the cell-free DNA leak. And this may be a new concept of how we think about it, right? And the thing that would support that, although it's not conclusive, is that we do know that this patient who, if you were to biopsy closely when the cell-free DNA was higher, but the biopsy did not show rejection, usually they do the same thing. They have longer-term worse outcome, meaning that lower kidney function, development of antibody or proteinuria. So it's change one of the things we think of when the rejection happened. Is it a clinical rejection mean we see creatinine going up, we see things in the biopsy that mean rejection happened, or it already happened all along, but we are just too slow to pick it up. Now, what does it mean for us, right? So for us, we don't treat the number of cell-free DNA. What we are treating is we want to make sure whatever we do, we make the kidney last longer with the minimum side effect from immunosuppression. Because we cannot just throw the kitchen sink, increase immunosuppression if we don't know if the patient had rejection or not. So we have to balance, right? So if we pick up the rejection or leakage or injury earlier, we might be able to intervene earlier. And that is a big if as well, because all this medication, we think more maybe tone down the immune response and tone down the rejection. On the other hand, we still need the study to figure out what drug would be good for the patients and how we would do it, keeping in mind the problem with immunosuppression, over immunosuppression. So at the end of the day, right, what we want to do is to individualize immunosuppression. We want to look at you and say, you need this much. We don't want to look at the other one, you need this much. And what are the factors that contribute to that? So we look at certain characteristics that we categorize them, but not individualize them, right? We look at patient higher risk, had rejection before, is a multiple transplant that maybe need more medication. We look at older patients that may be more likely to be susceptible to infection and cancer, and you need less immunosuppression. So what we are hoping to see for the biomarker as a whole, not just the cell-free DNA, is to look at how we can monitor the patients earlier and hopefully can tailor immunosuppression. Before we talk more about it, maybe it would be fair to say what are some of the limitations of the study before we can look at how we, generalize the result and what study we would do next. This is the largest study, retrospective study, registry 5,000 patients, the data that we had for the first 1,000. So we have more data when we have 5,000 patients at 1 year. When we talk about the marker for rejection, if you want to have a perfect study, then you would want to have not only the kidney function or the antibody with rejection, you want to do so-called protocol biopsy, right? You have a rejection. In this study, is a real-world test. So we don't really actually do biopsy on every single patient. So the ideal one would be you want to biopsy everyone at a certain point. You want to know how physicians, surgeons take that information of the cell-free DNA and biopsy and treat them, right? Because those were not taken into account. But this gives us a good opportunity and, to look at how we can do this patient better, take care of this patient better. Meaning, one, we do know that this abnormal cell-free DNA is not that uncommon. It's actually happened in a so-called subclinical setting, mean everything else look great. Without this test, you'll be looking at the patient and tell them that, you know what, everything is fine. So please go home and be happy. And this is your immunosuppression dose because of this level. But now we do know we have technology to look at a subgroup of patients that may not be quiescent in terms of immune system that you may want to take a look more into it. It would give us opportunity to then do the biopsy in a selected group of patients rather than to say, I would look at everyone, because a biopsy also comes with the risk, and it's not that it's expensive as well, and you cannot keep doing it that often. There's still a lot more to learn. We look at the number and say which one positive and negative. We have more than one cell-free DNA. There are people that look at not just the positive or negative. We're looking at the change. If the patient have this low cell-free DNA for many times and nothing has changed, maybe those patients you safe to say that they are pretty much inactive or quiescent. When you have kind of borderline level, maybe these patients are more at risk. You also want to use this information like anything else in medicine, right? You not just look at one data. Look at the patient. You look at their risk profile. We look at antibody to the kidney. We look at immunologic risk, the risk of rejection. Then we can take care of the patient better. So I'm hoping, prediction the next 3 to 5 years, I'm hoping to see that maybe one test is enough in certain setting. It depends on the context, right? In this case, we look at injury to the kidney by the leakage of cell-free DNA. There are certain biomarkers in the market that looking at the immune system itself. Try to look at, okay, if the gene expression, how much gene is expressed this way, then there is more activation on the immune system. Could be one or the other, could be the combination. And obviously, at the end of the day, it's great to start with diagnostic, it's very important, but we need newer, better medication to be able to treat the patient with the least side effect. So it has to come from both. But it's exciting. It's exciting that we know that we now can look at this rejection maybe earlier. Hopefully it would give us window of opportunity to treat the patient earlier. But those still would need research. This cannot be just, okay, this is what it is. We treat patient with that. We are not there yet. But it's very exciting. I would say for our nephrology times audience, general nephrologists, we want you to realize that there are many biomarkers, three or four of them in the market now, and they are used in certain contexts. In the last paper that we published on a very large study, we see this correlation. I think the transplant program still need to take the lead to look at more of this, how we're going to be using them for the general nephrologists to be able to use them comfortably and helpful to the patients.